Welcome to Health in Today's Woman. I'm your host, Dr. Kelly Williams. As always, this show is designed to help women become champions of their own health care. Tonight we're going to talk about a topic that many women will deal with as they age, and that's the idea of hormone replacement therapy. Now, earlier in this century, around 2000, we had the development of a study called the World Health Institute study. And most of y'all will know this because this is a study that everybody talked about that changed the way we looked at hormone replacement therapy. Well, tonight we're going to take a look at that study as well as many other issues that face hormone replacement therapy. To help me better understand that, I have invited Amy Mulder, who's a nurse practitioner at the Murfreesboro Medical Clinic and head of our female specialty clinic. And she runs a hormone clinic at the clinic. So I want to talk to you a little bit. First of all, I want to say thanks for being willing to come and be here tonight, Amy. And I want you to tell us, kind of start off with this whole idea of this female specialty clinic. What is that about?
Well, we designed the clinic to address hormone imbalances, menopause, perimenopause, even can go back to PMS and things like that. But basically, the idea is individualized care and very rooted in education and well-informed, making the patient well-informed so that they can make their own decisions on what they would like to do.
Well, that's great. And that's one of the things that we have really preached in this show is really patient education and patient understanding. And I want to make sure everybody understands PMS stands for premenstrual syndrome, and that's patients who are having problems with mood disturbances and stuff right before their period. Now, the other thing is, Amy, you've done some extra study here, and I want to make sure we highlight this because you have. You've done some extra study in menopausal work. Go through some of that stuff that you've done.
Well, I'm certified through the North American Menopause Society as they refer to it as nationally certified menopause practitioner. And basically it's a continuing education on menopause-related subjects, including hormone replacement therapy, but also just overall care of the menopausal woman, from cardiovascular health to osteoporosis to just the overall well-being.
And this is great because I think we're now starting to move into a full care of a patient. That's one of the things that this clinic started about 2.5 years ago with Amy and I developing a clinic for sexual wellness and is now developed into a full service hormone therapy clinic. Now I want to take some, now we've got a little bit about what this clinic is doing. Now we want to talk a little bit about how people can utilize this clinic and how we can help these patients. So I want to start off with a lot of patients are really concerned about hormone therapy. This whole idea, the WHI and concerns about, is it good or is it bad? Kind of where do we fit in here? But I want you to explain, who are those patients who need to be treated?
The people, the standard of care today when it comes to hormone replacement therapy or any kind of menopausal treatment is the treatment of quality of life symptoms. So those that are having problems dealing with hot flashes, night sweats, insomnia, we no longer use hormone replacement therapy for preventive medicine as we did prior to the WHI. That to me is the largest change that occurred with the WHI. We absolutely know it's wonderful for the bones. We absolutely believe that it's actually good for the cardiovascular system if started early in the transition. But standard of care calls for treatment of symptoms.
Now let me ask you this patient who says, do I need to be on hormone replacement therapy or should I go to this clinic? What do you tell that patient? What kind of things are you looking for to say, yeah, you probably would benefit from hormone replacement therapy?
If they're having any, really any symptomatology at all, so that may include as we said, the hot flashes or night sweats. That may include vaginal symptoms, vaginal dryness, pain, can be irregular cycling and things such as that. Most of the patients that I see have actually come from the gynecology world. So they, as far as the irregular bleeding things, they have been worked up for that, so it's usually more symptom control.
Okay. And let me ask you then this. So the patient says, okay, this is something that I have. I want to be seen for this particular issue. What kind of tests are they, what can they expect when they get there? What kind of tests are you going to run? What kind of ideas are you going to evaluate?
Well, the main thing I like to stress is it's a lot of time to listen to the patient. There's a questionnaire that they fill out. It allows me to really try to hone down on what the imbalance is based on just what they're telling me. But we do blood work. We do serum testing. it's very individualized. For someone, it may be to see if they are menopausal or are they not. It may be, I do thyroid testing. I do vitamin testing, actually. Fatigue happens to be a huge issue.
Okay.
And I never want to assume that's a hormone imbalance. So we do other testing as well.
Now I want you to address this issue because I hear this a lot. Everybody who's got a problem, especially females, especially as they get older, it's all hormones.
Right.
I think you brought up an interesting thing that it's not all hormones. There's a lot of things that can be involved. And one of the things I like about what you're saying is we're not honing in on just medicines.
Absolutely not.
We're actually trying to find a breadth of ideas that may be helpful. Is that right?
Yes. Lifestyle education, also alternatives, product alternatives. What can we use to help us with night sweats at night that are not medication at all?
Right.
And things, we address things like that as well.
And are we hitting a success from these patients?
Absolutely. Yes.
Okay. Now I want you to go a little bit. Then, what are some of the basic treatments? I mean, because we do have some medical treatments. There's no question that medical treatment is out there.
Sure.
What are some of the basic medical treatments that we utilize in these patients?
Okay. Hormone replacement therapy. I break that down into estrogen, progesterone, and testosterone.
Okay.
That's probably oversimplifying it, but estrogen, for example, I really very much believe that transdermal, which is the medication that goes through the skin, the bypass the liver metabolism, is very important. It's been shown to decrease the risk of clots as well as not increasing triglyceride levels from a health standpoint. Progesterone, testosterone, we usually do transdermal. Testosterone, we right now use compounded because there is no FDA-approved testosterone for women in the U.S. There's one very close to approval. We'll see if that happens or not with FDA. But then there are antidepressant medications that obviously treat symptoms that can be associated with moodiness and irritability that can be associated with menopause, but they've actually been studied to also help vasomotor symptoms, which mainly we're talking hot flashes and night sweats.
Okay. We're going to be right back after these messages. We're going to continue this discussion about hormone replacement therapy and menopause. We'll be right back. Welcome back to Health in Today's World. Tonight we're talking about hormone replacement therapy and menopause. I've been joined by Amy Mulder, who's a nurse practitioner at the Murfreesboro Medical Clinic. Now, as we finished the last segment, we were talking about the different types of hormones that we use to treat menopausal symptoms and hormone imbalances. So in this segment, I want to kind of open it by talking about some of the different FDA-approved things that are out there for hormone replacement therapy. And so, Amy, I want you to kind of look and see. We've got a bunch of stuff kind of here on the table. I want you to talk a little bit about it. First of all, this looks like it's kind of we've got a gel. I think these are both gels. Tell us a little bit about the gels and why these are more important. This looks like it's a gel also.
Those are all three. The gels, those are the transdermals that I spoke of before.
Right.
They are put on different places. The two pumps you put on your arm. The one in the box you actually put on your leg. They each have their small differences. Half-lives, absorption, but overall they're basically the same thing. And the key is that it's going through the skin into the bloodstream and not through the mouth and through the liver.
And a key point here, so I want to make sure we point this out. The big difference is when you swallow a pill, the first thing it does is goes to the liver and it's broken down.
Yes.
With these medications, it goes directly into the bloodstream, so the effect is a little bit different, and you don't have those metabolites or breakdown products that you associate with the liver. Is that correct?
Exactly.
And this is becoming much more common these days, isn't it?
Right. And once again, the major reason, or two reasons, are the decreased clotting risk as well as triglyceride levels. And as we know, as we age, cholesterol and triglycerides are part of the lipid panel, or a huge issue. And my honest opinion is if we can bypass the liver, we need to bypass the liver.
Okay, so the next one, we're looking at something a little bit. This is also transdermal. Looks like we got a lot of transdermal stuff.
Yes.
This is transdermal. This is a patch.
Yes.
What's the difference in that?
The patch, the gels, I should say, you have to place every day.
Okay.
The patches, this one specifically, you do twice a week. There's also a patch that's once a week. The patches came out prior to the gels.
Right.
So that was actually our first transdermal option. And I don't feel strongly one way or the other. It's just an option. Some people don't want to put something on and rub on.
Okay.
Some people on the opposite side of that, don't like anything stuck to them. So it just is patient preference.
Okay, this last one over here, and then we'll come back to the other one,
Okay.
is an estrase cream. This is a vaginal cream. This is a little bit different also. Describe this to us.
The vaginal estrogens are meant to be absorbed in the vaginal tissue. There is minimal systemic absorption. There is systemic absorption. We can't say zero, but it is very small amount. We use these. There are the creams. There are also one pill that you put into the vagina. There's also a ring that's available, and they are meant to treat vaginal symptoms, whether that be dryness or pain and the like.
And these are issues that most of us going to stay in the vagina, correct?
Correct.
Okay. This last one I know is a compounded.
Yes.
And I know we've been using this compounded stuff a lot more in the clinic. Describe to me a little bit about what the difference is here.
Between the compound and the FDA. Compounded medications are made in pharmacies. They are the active ingredients, when we're talking hormones, testosterone, progesterone, and estradiol.
Right.
They are not FDA approved. They are managed through a different organization, but basically we use them more than anything to combine things. Like if I want to do estradiol plus testosterone, I do not have that available as an FDA option, so that it's a nice option to have the compounding medications for that.
Okay, great. Now, not everybody can take these medications, and there are certain people who are not candidates for these medications.
Right.
For example, we've talked about clotting. Somebody who has had a clot go to their lungs, or somebody who has breast cancer, they're not candidates for this.
Right.
How do we deal with those patients? Because those are the most difficult patients that we see.
Right. And the way I look at that is you have to get down to treating symptoms. So, for instance, if I have a somebody that's had breast cancer that is having vaginal symptoms, then we can work with vaginal moisturizers, different non-hormonal options localized there. Hot flashes, night sweats. Actually, a couple of the antidepressant medications work really well for that. Not as well as estrogen by any means, but we also have one hypertensive medication, and there's also gabapentin, which is a nerve medication basically that has been studied and shown to help with those symptoms.
Yeah, because this is one of those patients that really is a difficult person to manage. They already had breast cancer in there, and now they're going to have to be miserable. And their thought process is they're going to have to be miserable for the rest of their lives dealing with this stuff. The other thing I know we've talked about is some very practical things. Those wiki sheets you've talked about before.
Yes, they're products. Wicking sheets are sheets that are made, the way I describe them, they're made out of the material that a lot of the sportswear is being made out of, that basically wicks heat away from you. So they tend to work really well for night sweats. Chillo Pillow is a product that is a device that you can put inside your pillowcase that keeps it cool. And a lot of times it seems to be very important to keep something cool by our face. They're all, one of the things that I talk to people about are just vitamins and minerals that we need. I mean, nutrition.
Okay.
From that standpoint, there are certain things that are important to specific symptoms. For instance, magnesium tends to be very important for PMS symptoms, the moodiness and things like that.
Right.
The B complex medications tend to be highly related to headaches and different, so we talk about those types of interventions as well with everybody.
Now, I want to take a little bit of a turn here and turn to those patients. There's a large number of patients who, when the World Health Institute study came out, the first thing they did was we went to their doctor, and their doctor said, stop. This is the worst thing ever. I never want you to go back. Those are the patients who are now coming to see me and saying, okay, that sounded like a great idea at the time. Now I'm about to die from hot flashes, mood swings, night sweats, whatever you want to say.
Right.
I'm having all of it. What is the time limit, first of all, that these patients need to have waited? I mean, is there a time limit that's too long?
Yes.
And can these patients go back on hormone replacement therapy if there isn't a time limit?
The North American Menopause Society has kind of set the standard of 10 years.
Okay.
So 10 years postmenopausal. Now, the interesting thing about that, that's post last period. A lot of people have actually started this medication in the transitionary period, so that that may be 15 years for somebody because they were still in the perimenopausal stage when they when they started hormone replacement therapy.
I didn't know that. We're going to take a break. We'll be right back after these messages. We're going to continue to talk about hormone replacement therapy. We'll see you back. Welcome back to Helping Today's Woman. Tonight we're talking about hormone replacement therapy. In my first two segments, we talked about its effect on menopause. Hormones have effects on lots of different things. In this segment, I want to talk a little bit more about female sexual wellness and how hormone replacement therapy is involved in that. About 2.5 years ago, Amy and I started a clinic at the clinic where we were going to deal with women's female sexual issues in a way that was medically sound but also was comfortable for patients. That has now turned into our female specialty clinic over the last 2.5 years, where we've expanded to more hormones. But I want to talk a little bit about this because I think this is another involvement in hormone replacement therapy that most people don't think about. So let me talk to you about, Amy, a lot of people come to us. One of the big problems that we were seeing is this idea of decreased sex drive, especially as they age. How do we address that with patients that come to us?
Time spent, I will start by saying that again. The issue with specifically female sexual drive is that many things affect it. When we're talking hormone imbalances, what I oftentimes will explain to women is that we have to get you feeling better. And if we get you feeling better, the desire and the sexual wellness part will follow suit. For instance, if you can't sleep at night, and I do believe insomnia is a core problem of perimenopause and menopause, well, then all you want to do is sleep. Right. So we have to address the insomnia. Vaginal symptoms, that is huge. So many women come to see me to complain of decreased sex drive, but once you start talking to them, they've been hurting for years.
Right.
Well, then of course they don't, so that we have to address that. Testosterone absolutely comes into play there if someone's testosterone is low. Those are mainly, honestly, post-hysterectomy as well as ovarian removal patients. The interesting thing that I've learned through the research that I've done with the Menopause Society is that the ovaries actually produce testosterone postmenopausal,
right.
Which means to me it must be very important to us if we're designed that way to have it even after our estrogen and progesterone have gone down.
And ironically, this is something that we are now mentioning. I mentioned to all my patients that we do hysterectomies on, is we're leaving the ovaries behind because of the fact that we now know that testosterone is converted back into estrogen. So you have a base or a low level of estrogen that's produced even at menopause, is that right?
Right.
Yeah, I discuss that with all my hysterectomy patients now, why I don't take their ovaries.
Right. And it's much better if they can keep them, but obviously there are certain patients, endometriosis, for instance, that can't do that, and we can absolutely help them. They just need to know that we're there to help them.
And the other question I have for you, there's a lot of birth control really does have an effect on this sex drive. A lot of women don't realize that years ago, the acne indication that came out for orthotricycline that everybody talked about was really related to the fact that it bound up testosterone because that's what it's supposed to do. And if you think about it, birth control, what do you not want to do? If you don't want to have babies, you don't want to have relations. If you don't want to have relations, then you won't have babies. So it makes sense as a side effect of birth control. How do you discuss that with patients? Are there some that are better than others?
I first of all say they all do it, and what they do is raise a protein from the liver that binds up the testosterone.
Right.
The more potent progestins, which are the newer birth control pills that have come out in the last few years, are much worse than the older, weaker progestins. So weaker progestins, higher estrogen though, equals less sexual side effects. But I will tell you, they do it across the board. If I had an option for those people, an IUD would be great, an intrauterine device that would be more systemically, not systemically, but localized absorption to the uterus, and let the ovaries do what they want to do would actually be my optimal.
And I want to mention real quickly here what progestins are. Birth control has two components, estrogen and progesterone. Progesterone is not well absorbed, so we use progestins, which are very similar to progesterone. So a lot of people wonder what that is. It's just the other component of the birth control pill. Now the other thing that we see with a lot of patients is pain. And this is an issue that a lot of patients, you mentioned earlier that maybe the reason they're not wanting to have relations is because of pain. How do you address those patients?
Well, we try to, of course, figure out, we try to investigate to see what the root cause of the pain is. And that can be tissue, which would be more related to the lack of estrogen, lack of testosterone, and things such as that. Muscles. That's been amazing to me in these last few years, how much really we've learned about the muscles and ligaments and tendons of the pelvis, and addressing that problem with physical therapy, actually. So it's basically addressing the pain, and then some of those people, for instance, may need sex therapy, which is actually a counseling, because what happens over time is our brain is very powerful, and it will say, don't do that because it hurts, and it's very hard actually for a person individually theirself to train it to accept it again. So a lot of times those people actually need counseling, even if the pain is resolved.
Well, I have to tell you, 2.5 years ago, when I decided to select the nurse practitioner who was going to run our sexual wellness clinic and what has developed from there, I'm very proud that I chose Amy, because I think she's done a great job, and I think she's done an amazing job at making people feel comfortable in kind of an uncomfortable situation. We're going to be right back after these messages. Welcome back to Health in Today's Woman. Tonight we've had a great discussion about hormone replacement therapy. We've discussed its involvement in both menopause as well as female sexual issues. This is an issue that many women are dealing with. With the World Health Institute study, the changes that have occurred will continue to be discussed well into this century. I want to thank Amy Mulder, nurse practitioner at the Murfreesboro Medical Clinic, for being willing to be with us tonight. Thank you for joining us tonight. We hope you have learned and will have a better understanding of hormone replacement therapy, its positives and its negatives. Thank you and good night.